Welcome to the Explainer. Today we're talking about angina. You know, that sudden chest pain that's basically your heart's own built-in alarm system? But what's it actually trying to tell you? Let's get right into it, because this isn't just one single problem. It's a symptom, a sign of a really critical imbalance happening inside your body.
All right, so the official name is angina pectoris. And at its core, yeah, it's chest pain. But the reason for that pain is a temporary mismatch between your heart's oxygen supply and its demand. The technical term for this is myocardial ischemia, which is just a fancy way of saying your heart muscle isn't getting enough oxygen to keep up with its workload. And that pain, that's it screaming for help.
Okay, so this is where things get really interesting. See, angina isn't just one thing. To really get a handle on it, you've got to know that there are three main types, and each one has a totally different problem at its root. And this chart lays it all out beautifully. You've got your three main culprits. First, there's stable angina, which is caused by a fixed plaque. Think of it like a permanent lane closure on a highway. Traffic can still get through, but it's going to back up when things get busy. Then you've got vasospastic angina. This is where the artery itself just spasms shut, like a sudden temporary road closure. And then you've got the big one, unstable angina. This is a true emergency. A plaque bursts, a clot forms, and boom. It's a multi-car pileup that can shut down the whole highway. So, let's start with the most common one, stable angina. It makes up something like 90% of cases. The key word here, really, is predictable. It's caused by that fixed narrowing in the arteries from atherosclerosis. So, when you're just chillin', blood flow might be totally fine. But the second your heart is to work harder, that's when you run into trouble. So what exactly makes the heart work harder? Well, here are the classic 4 E's to remember. First, exertion, like climbing a flight of stairs. Second, emotional stress. Third, exposure to really cold or hot, humid weather. And fourth, even just eating a big, heavy meal. The thing is, they all have one thing in common. They crank up the heart's demand for oxygen, a demand those narrowed arteries just can't keep up with. Okay, so if we know what causes it and what triggers it, how do we actually manage these chronic types of angina, the ones that aren't immediate emergencies? Well, the strategy has to be really targeted. You have to match the treatment to the specific problem. When it comes to stable angina, we've basically got a toolbox with 3 main classes of drugs. We're talking nitrates, beta blockers, and calcium channel blockers. And each one has a slightly different but pretty clever way of tackling that fundamental supply and demand problem. Let's kick things off with nitrates, like the famous nitroglycerin. Their main move is something called venodilation. What does that mean? Well, it reduces what's called preload. The easiest way to picture it is that they basically widen the pipes, the veins, that bring blood back to the heart. So less blood is rushing back all at once, which means the heart doesn't have to stretch as much or pump as hard. Its workload drops, and so does its need for oxygen. Pretty neat, right? All right, next up, beta blockers. These are a huge deal. They're often the first choice for preventing stable angina attacks. And they work by hitting that oxygen demand problem from 3 different angles. They slow your heart rate down, they make each heartbeat a little less forceful, and they lower your blood pressure. It's kind of like putting a governor on your heart's engine just to make sure it doesn't redline when you start exercising. But hang on. What happens when the problem isn't that fixed lane closure we talked about, but that sudden road closure? A spasm? Well, you can't use the same game plan. In fact, using the wrong one isn't just ineffective, it can be downright dangerous. And this right here is a perfect example of a super important concept, the beta blocker paradox. For stable angina, they're fantastic, but for vasospastic angina, they're contraindicated, which is a big red flag that means do not use. Why? Well, it gets a little technical, but basically blocking certain beta receptors can leave these other alpha receptors unopposed. And those guys love to constrict arteries, so you can actually make the spasm worse. Instead, the go-to drugs here are calcium channel blockers and nitrates, because they work to directly relax that spasming artery. Okay, now we need to totally shift gears. We're leaving the world of chronic management and jumping into the most dangerous type of angina, the one that's a full-blown medical emergency. So what's going on with unstable angina? It's all about a plaque that has ruptured. That rupture is a major injury, and it triggers your body to form a plug made of platelets. This isn't just a simple narrowing anymore. This is an active, evolving blockage. You're literally a hair's breadth away from a massive heart attack, and this needs immediate, urgent medical help. For years and years, anyone in emergency medicine learned a simple little mnemonic for how to treat this kind of chest pain. But as medicine evolves, we're learning that this old rule of thumb isn't always the best move. It's time to rethink it. And here it is, MONA. Stands for morphine, oxygen, nitroglycerin, and aspirin. The saying was, MONA greets every patient with chest pain at the door. It's simple, it's catchy, it's easy to remember in a crisis. But let's take a much closer look at that M and that O. So the big question is MONA always the right move? And the answer is no. A lot of recent research has raised some pretty serious red flags about just automatically giving 2 of these 4 things to every single patient. Let's start with oxygen. I mean, it seems like a no-brainer, right? The heart isn't getting enough oxygen, so just give it more. But here's the crazy part. For patients who aren't actually low on oxygen to begin with, giving them extra can actually be harmful. It can increase resistance in the coronary arteries, basically squeezing them a bit, and it can even create these damaging things called oxygen-free radicals that cause even more injury when blood flow finally comes back. So because of those risks, the guidelines today are way more specific. The current thinking is that you should only give oxygen therapy if a patient's oxygen saturation level actually drops below 90%. The point is to treat a specific problem, low oxygen, not just to give it to everybody out of habit. Okay, and what about morphine? Well, besides some lingering questions about its safety in this setting, we now know about a really critical side effect. It slows down your gut. And you might think, so what? But it's a huge deal. Why? Because it can seriously delay the absorption of life-saving antiplatelet drugs like clopidogrel. And if that patient is on their way to get an emergency stent, delaying that drug's effect can have some really, really serious consequences. And this brings up another super important point. The kind of clot you see in unstable angina is mostly made of platelets. That means those big gun clot-busting drugs, the fibrinolytics, just aren't effective. They're designed to bust up a different kind of clot. Using them here doesn't really help and can cause all sorts of dangerous, unnecessary bleeding. It's all about using the right tool for the job. You know, this whole journey from the simple MONA rule to a much more cautious, evidence-based approach, it's just a perfect example of how medicine is supposed to work. It gets better. It's not about being stuck in our ways. It's about being willing to question what we've always done when new evidence comes along. So if there's one thing to take away from all this, it's this. You have to understand the why behind the angina. Is it a fixed plaque, a sudden spasm, or a dangerous rupture? Because knowing the cause is the absolute key to picking the right treatment and, maybe even more importantly, avoiding treatments that could cause real harm. And that really leaves us with a final, kind of profound thought about modern medicine. You know, it's not just about knowing what to do. More and more, it's about having the evidence and, frankly, the wisdom to know when not to do something. True expertise, a lot of the time, isn't in giving a treatment, but in that careful, considered decision to hold back.